So, good evening, everyone. Great to have you all join us on a Sunday evening. I know people like to take their Sundays relax, but this topic is important and urgent for us to hear what Dr. Indhumathi Kuberan has for us. So, I'm Dr. Vinita Mathew. I'm a co-founder of the Raahat Wellness Center. We are based here in Daisar, Mumbai, and our vision is to give whole person care. We want to do this, um, basically reach out to people so that they would be healed in a holistic manner, not just the body, but mind, body, soul, and spirit. So that's how the concept of Rahat has come about. We have a team of mental health experts on our panel, and we are, open to doing counseling sessions and other awareness sessions. Our whole idea, especially even with this awareness session, is to educate people on how the mind affects the body, and what we can do to make that or bring about holistic changes in a person's life. Okay, so today I have Dr. Indhumathi Kuberan. She is a diabetologist and endocrinologist, and she has been seeing an increased number of um, uh, you know, uh, patients, especially young children, who have been detected with diabetes, obesity, many other, endocrinologically, diseases, sicknesses. And she is very much passionate, similar to what the Rahat vision is to give whole person care. She's also uh, learned and been educated through CMC Vellore. Many of us know CMC Vellore, and she's also passionate about giving holistic care to patients. So today I'll be interviewing Dr. Indhumathi. She will tell us a little bit more about herself as she starts, and I will be kind of just we'll be having a conversation, and then at the end of the whole conversation, we will open it up for people to ask questions. So if you can keep your questions, maybe you can keep putting it on the chat box. Maybe the questions will be answered during the course of the time, but at the end we'll definitely have a time for Q&A. So Dr. Indhumathi, I want to just invite you. Maybe you can first uh, just tell us a little bit about yourself and your passion.
Yes.
So,
Good evening, everyone. It's a pleasure to be associated with Rahat. And this is the first program I'm doing in collaboration with Rahat and Dr. Vinita. And I've always been passionate about preventive medicine, especially primordial prevention. And since I'm also alumni of CMC Vellore, where they stress upon whole person care instead of just treating organs, so I take this opportunity to start off with the childhood obesity and childhood endocrinological diseases, which affects them mentally, and the whole family is actually affected. So I'll share some examples with you as the conversation develops. So I practice diabetology basically in Mira Road and Borivali, and I'm associated with Ashok One Hospital for a while as a consultant.
thank you so much, and thank you for accepting the invitation to be part of this conversation. So, we know that childhood obesity, we talk a lot about numbers and scales and those kind of things. Is it just about those numbers, or is there a deeper story, involving the family? Like you said, the family gets affected. So there's family dynamics, there's school stress, there is cultural habits, food habits. So can you just, tell us more about those things?
Yes, it's not only about the, as you said, about the numbers. It's not the kilograms or the pre-diabetic stage with the child presents with. It's a whole lot more than that. And mostly during consultations, the child is accompanied by with both the parents, but sometimes, most of the times, it's either the mother or the father. And what I have observed in most of the situations is one parent is empathetic, and the other parent, whoever it is, the father or mother, is thinks that it is the child's fault that he's obese and he has developed this pre-diabetes, and he has landed them in this situation where they have to see a doctor, spend for the health purposes. That's what I see. And the worst part is the empathetic one will be the one who's not very educated, mostly the mothers who are housewives. Whereas the one who finds fault with the child is the more educated one, who has more access to various latest developments in the field of medicine. So we have to also, take all these factors into consideration when treating the child, because parental cooperation and empathy from the parents and the siblings, the other siblings who are normal weight and don't have these problems with the weight and diabetes. So the all the support from the family support is very important in tackling this obesity than just dishing out tablets and writing a diet chart and exercise. That will not do. That doesn't give proper results. The outcomes are better when the whole family is involved, and gently sometimes the father or the mother who's very antagonistic and who finds fault with the child, gentle prodding is required, and gently the message is passed on that this is not how it works with children.
Very true. Very true. Thank you so much. One second. I think somebody's. Yeah. Can you? Yeah. I'd request participants to be careful of your mic. Just keep it on mute. Thank you. Yeah. So I wanted to ask you, doctor, that we are seeing a alarming, like we said, you said, alarming raise in preteen and diabetic, teen diabetes, which is often linked to sedentary lifestyle and the high processed food that we are consuming now. So, but how do you see emotional factors, kind of like bullying, body image struggles, all these kind of having an correlation or having an effect on the physical risks of a child or a teen?
Yes. See, now the situations are completely different from what we grew up. We grew up in a time when there was no internet. We just ate three meals. We It was mostly home food. We did not have much access to outside food, so it was a completely different story then. Now the situations in schools also, it's so different from what we had as school children. That's what I realized. So this classes, we did not have these classes right from class 8. So now the teens and the preteens are pressurized a lot because of too much of rote learning. It is not a practical education model which most of the schools are following. And the children are not, they have remedial education or remedial measures for other things when the child is not doing well in studies. But the other factors are not taken into consideration. For example, if the child is dull, if the child is not opening up, if the child is not mingling properly. So all these small subtle signs of depression or childhood anxiety is often ignored both by the school authorities as well as the parents. And there is no remedial education about this, I feel. Most of the remedial measures taken by the schools are mostly focused on education
Education.
and bringing up their marks or academically. It is oriented academically. It is not focused on the mind. And when the child is a bit overweight or even obese, bullying starts not only from their peer groups, but in other ways also they are bullied. So I would like to tell one small example which really shocked me. There was this boy of around 14 years brought to me by his mother. She was not very educated, but she was a wise woman. She understood that he needed medical care. So this boy was brought to me with recurrent episodes of fainting. That was the only complaint. She said, "Ma'am, वो बार बार गिर जाता है, बार बार बेहोश हो जाता है." So when I saw that boy, it was not very hot in Mumbai or cold in Mumbai. It was a pleasant evening, and he was wearing three shirts over his normal shirt. There were three shirts, and over that he was wearing some a jerkin or a sweater, if I remember right. So I asked the boy, "Beta, why are you wearing so much of overclothes? I was thinking about thyroid, hypothyroidism, where the child is feeling cold." I said, "Why so many overalls? Why are you wearing so many overalls? Are you feeling that chill?" He said, "No, ma'am." And suddenly broke down and said, "Ma'am, I'm little overweight. I have these bulges here, and the classmates start pinching me when I'm in school. So I wear all this and go. Even if it's very hot, I wear them." And that was causing him to faint because of the temperature. So it was very heart-wrenching. I told the mother about this. I told her, go to the school authorities, talk about this. And then we did a workup on all his health. Of course, he was a pre-diabetic, but more than that, the emotional impact the impact which was on the child shocked me more than his medical problems. So the child was trying to hide his
Hide
bulges
it.
and escape the pinches from his fears, and he did not have the courage even to tell his sympathetic mother. So
Hmm.
he ultimately broke down in my cabin, and then we found the medical cause of the frequent fainting episodes. Very
Okay.
heart wrenching, and
Sad.
that's why I said we have to go to the root of the problem rather than search for medical reasons.
True. Very true. Thank you so much. That's very it's very sad, but thank you for highlighting that. Another
In
aspect
fact, this
is,
child was referred to Raahat for
oh yeah,
under the.
okay,
So I told them he needs professional help. If we can't do it on our own, and I'm a
great,
diabetologist, so I won't be able to counsel this kid. So I think he's under Dr. Pooja. I'm sure
right,
they are. Yes.
great. Thank you. Okay, so beyond HbA1c and BMI, what are some of the subtle emotional red flags in a teenager's behavior that might signal that there is uncontrolled diabetes, or how can the family or the family physician spot them early? So here we have some family physicians also on this call, and some, of course, parents are there. So can you
Yes.
tell us how we can do that
So when
before?
any young, yeah, yeah.
Yeah,
So when any young child develops male children develop balanitis, that's a red flag. So immediately check their sugars. And girls also, very rare to find young girls, teenagers with vaginal itching, which is unheard of. But nowadays, it is very common. And they are very shy to open up even to the mother. So there should be leading questions when the child presents to you. There should be leading questions. And another thing, especially for the family physicians, even if they come for some other purpose like a viral fever or a cough and cold, if the child is not making eye contact to you, that sign is very, very subtle, but it's a very important sign not to miss. The child is having his head down and not having eye to eye contact with the physician, then that's definitely a red flag. Because confident children who have good mental health and who have a happy family situation, they look eye to eye. They are jovial. They in fact they most of the history is shared by the child. But when the child is silent, it's not looking in your eye, and most of the history or whatever the story is narrated by the parents or the person who accompanies the child, it's a red flag. It's a very subtle sign, but it's a red flag which should be caught. Because most of the times I tell them, "Aap thoda chup beta, I want to talk to the kid." And only when you make the kid look at you and open up, especially this kid with many coats, once he made eye contact, he broke down. So this looking down and crouching and having a body language which is not confident, unhappy, these are subtle signs we should look out for, and not wait for the person, or there is no direct thing like mother will not come and say or father will not come and say my child is depressed. These are all very subtle signs we should pick up.
very true. So, have you, like, you've definitely encountered a lot of these kind of things where teens with, obesity, when it triggers anxiety, low self-esteem, and then it turns a metabolic issue into a mental health crisis. I think you've just kind of touched upon it right now, but can you like kind of share a bit
Yeah.
more about?
It actually becomes a vicious cycle, Dr.
Mhm.
Vinita. What I've seen is PCOD girls, the obese girls, as well as the boys, once the peers start picking on them, bullying them, and they are considered a failure, even if they are academically good, because
Hmm.
of their weight, they are considered a failure by their peers as well as the teachers, there is some partiality going on in their classes based on the look of the child. And mainly the parental, as I told you, one of the parent is very not empathetic, and they blame the kid for everything. So the kid becomes withdrawn, especially the girls I've seen. uh, they feel they can't get into good clothes. They compare themselves with the other teenagers. See, this is the time they bloom and they want to look good. Peer pressure more for the girls than the boys, I feel. And they become homebound. Most of the girls, they become homebound. And when I tell them, just go for a walk, just, prodding them to go for a walk, even for 20 minutes, it's not that they don't want to go for a walk, they just don't want to be seen outside in public. So that is a very dangerous sign, because it's a vicious cycle. Unless we break that cycle, we bring the child out of the thing that you are good looking, you are not lesser than others in any way. The child is not going to follow any diet and exercise program which we are going to. So that vicious cycle, to break the cycle, the parents also have to cooperate, which is, I don't know, it's very difficult from my, because I can't give more time to them. So most of the time, the vicious cycle goes on and on till the child becomes very sick.
Yeah, very true. Yes. Um, so like now we are the Indian community. We are juggling with fast food, temptation. There are traditional foods. Our I think our dietary habits itself has a lot which we need to change in, like, ours is a more carbohydrate rich diet. So what are some practical non pharmacological strategies which you can give us, like, which blend diet advice, emotional support, which would help to prevent diabetes from progressing? Because I know, we all know that diabetes progresses over the years and it affects every organ of the body. So,
Yes.
can you give us some tips or ideas? How do we do this?
Yeah. See, nowadays, Dr. Mehta, if you remember when we were interns, young MBBS doctors, children with diabetes was always type 1. There was never a concept of type 2 in teenagers, never. So this is all a new thing. We are learning new things. So the primordial prevention or the lifestyle modification has to begin at home, not at the doctor's cabin. So in most of the families, if you see, especially if the mother and father are working, they themselves will be foodies. They themselves will be junk eaters, and they will have a lot of I don't know, the apps installed. And most of these teenagers also have apps installed in their smartphones. The mobiles are actually given to the child to get into online classes, and I don't know. It's mostly for the coaching for their various courses which they are on, but it is actually misused for other things. And one of my patient, he was a 15-year-old boy, 10th standard boy, came to me with 14% HbA1c. In fact, he was wrongly diagnosed as type 1, and he was on basal bolus insulin when he came to me. Then we did the C peptide and understood that he was type 2. Now he's just on metformin, doing well. But then what was really very evident in this case was he was throughout the days hooked on to reels. I asked him, why you are, even you're not looking at me, why are you looking? So he said, ma'am, I love to see Insta reels. He was hooked on to reels. And another thing, what I've seen is they have this vicious cycle of eating very fast junk food. So that increases their insulin levels. And in 2 hours, they are very hungry. It is that reactive hypoglycemia, which the parents don't understand. दे फील वो राक्षस जैसा खाता है, अब भी खाया डॉक्टर 2 घंटे के पहले, नाउ ही वांट्स अनदर plate full of noodles or whatever. They don't understand that it is physiological. The child has eaten a big load of carbohydrate, stimulating the insulin release, and after 2 hours, the insulin crashes and he gets that hunger bouts. But when we explain, most of the families, they understand, okay, the child is not doing for enjoyment. It is a reactive hypoglycemia which the child is trying to overcome by eating and eating and eating. Even this point has to be, talked to the parents. And then the child also, we tell them, "Do thoda dheere dheere kha lo, eat ghar ka khana." And it is a slow process, Dr. Vinita. We can't just wean them off from junk food altogether in one day. And the doctor's words also, we cannot talk about, आपको sugar hai, your blood pressure is mildly high. your ideal BMI will be 23, you are now 30. You can't use such words. The child becomes even more withdrawn and he will never come back to the doctor. So it's a very tricky situation. That's why I thought, my God, I'm getting all these patients in my cabin. What can one single person do? So all the thing, it's a teamwork. And I feel the primordial prevention has to happen in schools, as Dr. Matthew has suggested. It's a teamwork. One person cannot envision the solution for such a big booming problem.
Very true. Very true.
Yeah,
Um,
just a
yeah,
pause here. Many of the people in the audience may not be medicos. So when Dr. Indhumathi mentions about type 1, type 2, C-peptide, it must be all going over the head. So we need to just break it down into something very simple and applicable for the people here. So
Okay.
essentially what she's saying is type 1 and type 2 are the two basic types of diabetes which are there in human beings. And type 1 diabetes is where there is deficiency of insulin production right from childhood or infancy, and they are called as insulin dependent diabetes. And type 2 was the type of diabetes that we used to see in adults. And that was because over a period of time, these people had adequate insulin production in the body. In fact, God has given enough of insulin production for us to last for our entire lifelong span of 80 to 100 years. But unfortunately, due to various circumstances, there is a mismatch between the insulin production and the insulin requirement in adults, because of many causes, which causes a type 2 diabetes, which is adult diabetes. So these are two things which Dr. Indhumathi mentioned, and I felt it is important to understand here that so many years that, like, I've been in practice for 30 years, so we have, whenever adult patients come to us, we assume that they are type 2 diabetes, and children as type 1, because these are the ones in which type 1 is the predominant diabetes in children, because these are the ones who are diagnosed early. But nowadays, the type 2 diabetes of adults is seen more and more in teenagers, and it's a big concern. That's why Dr. Indhumathi has mentioned that. And the other thing was about C-peptide. So C-peptide is a hormone released along with insulin in the production of insulin. So maybe Dr. Indhumathi can just clarify what exactly C-peptide is also, so that then before we go on to the other aspect of this probably. Yeah.
Yes, sir. So C-peptide level is a very simple test, just like a sugar test or the other test which we do, a cholesterol test or a liver test. And this is the essential test because sometimes you may be seeing kids with type 1, as sir said, a kid with where the insulin levels are really, really low and the child really needs insulin. It's not a type 2. So we cannot generalize. This child has eaten too much of sugar, too much of junk food, and now it is coming with diabetes. It's not like that. Especially most of the type 1 children, the history will be, ma'am, after she uses the bathroom, he or she uses the washroom and comes out, there are a lot of ants on the toilet seat, is what the history I elicit. And mostly that is due to type 1. Type 1 means the child is deficient of insulin and it needs insulin for life. And not diagnosing it correctly and delaying insulin treatment will be very detrimental to the child's health. So the C-peptide level is just a blood test. Just do the blood test when a child comes to you, especially the family physicians comes to you with diabetes, and when you're in a dilemma to think what is it? Is it type 1 where the child needs insulin, or just type 2 where the child needs just counseling and diet and exercise? Just do this simple test. And it's very easy to remember the value. It is 1. Below 1, it is type 1. Above 1 or especially high C-peptide levels 4 or 5, the child has insulin resistance. The treatment is completely different for these two classes. So we have to bear that in mind when we have children uh, coming to us with high sugar levels.
thank
And there
you.
is many myths that type 2 diabetes, the children will present with borderline sugar levels like 120, 130. This also is a very big myth. I get type 2 diabetic children, proper diabetic children, even with 14% HbA1c. So we have to have our mind open and rule it out and categorize the children properly so that the proper type 1 children are not denied insulin early.
Right. Thank you so much. Yeah, thank you, Dr. Matthew, also for bringing that up. Yeah. Another aspect which I wanted to ask you is like, how does diabetes diagnose impact teenagers' self-esteem, like his identity, especially in a society where we are looking, everyone's looking, wanting to look fit, ye patla hai, ye mota hai, all those kind of words that people use. And even when they go into social gatherings, I've heard, actually, in fact, I recently counseled somebody who was, saying that people talk about uh, the way she is, especially her weight, that's constantly being talked about when she's in a public setting, and she finds that it has affected her. So, can you just tell us a little bit about this?
Body shaming has always been there, Dr. Vinita, even when we were kids. Of course, social media was not there. So we were sheltered for uh, a little bit. But now with the social media and, bragging about one's appearance and all that in the social media, kids have extra pressure. What we had those days, they have 100 times pressure to, to fit with the crowd. So this also is a very what to say delicate line, which I have not been able to manage in my clinic because of the limited time. Here, the mental health experts have to be roped in to probe deep into the child's low self-esteem and weed it out. So step by step, it's not a one day thing to even get the full history. It will take a week of questioning and sitting with the child to know how deep is the rot, and then it will take another some weeks for the particular team to face this and treat it. At my level, clinical medicine, it's very difficult. Though I can identify child is disturbed and child has very low self-esteem, I'm not able to probe too deep. I just, of course, I direct them to the proper doctors. And most of the children with the low self-esteem, they also do academically. They suddenly, after seventh standard, when they were toppers, the academic performance comes down because of this low self-esteem. So, from my clinician point of view, I'm not able to handle it alone, I must say. I'm not able to probe it further.
Yes, I know it is a team effort, like
Yes.
you mentioned before. We can't do this alone as a diabetologist in a busy OPD or in a physician's, cabin. You cannot do that. It needs the whole team
And
to
even the
help with it.
parents, Dr. Vinita, when they
Yes,
enter, they feel that she's a sugar doctor. So, what is she talking about? Why is she probing so much into my child's life? They feel, let us get on with the business and, write a pill or whatever. What is she
right,
probing about? Especially
right,
the fathers who are in a hurry to go to their offices, they don't find my approach uh, very too much to their liking.
correct, correct. So, how have you handled, teens skipping their meds because of shame or, peer pressure? Again, this is another thing, like, people, children may be feeling, oh, at such a young age, I have to take this medicines at this time. Maybe in school, they need to take something. So, have you had such kind of situations
No,
where
no,
the
with the
child is
no, no, that has never been a problem because it's mostly once a day medicine,
okay?
mostly metformin. At the most, if the HbA1c is very high, we give them metformin sustained release along with diet and exercise. And it is mostly it's once a day. It's either
Okay,
500 SR in the night or 1000 SR. It is never multi-dose like the adults. And
okay,
they respond very beautifully to once a day dosing. Both the PCOD girls as well as the boys, they respond very well. So there is no stigma. Only this type 1 boys and girls who need to take multiple insulin
insulin,
injections in school, they face this problem. So that is a
right?
bigger, of course, we send them to juvenile diabetes educators. There are teams for that to handle that. But type 2 diabetes children, apart from the mental counseling, the tablets has never been a problem because
Oh,
it's once a day dose only.
right, right. Thank you. Um, how have you handled, I mean, or have you seen cases where, like especially where maybe the parents are not very affording, low resource,
Mm, mm,
communities. Um, how can primary care team deliver holistic care that tackles both diabetic control as well as emotional well-being? Do you have any idea of maybe your friends who have been in those
Yeah.
situations? Have you?
So, so to tell you the truth, actually, the middle class or the lower middle class parents are more sympathetic towards their children than the so-called affluent class. So the affluent class are somehow detached from their children. They feel, okay, my child has diabetes and overweight. You're a doctor, and you go ahead, and there is no, family discussion. Whereas, of course, I don't get anybody from the slums, but the lower middle class, like they are a family, a big family living together, hold up in a 1 BHK or a 1 RK. Those people have, the children get a lot of support out of the family, especially when there are grandparents to rally around them. I find my job getting easier. Whereas this affluent class, especially the nuclear homes, they are very detached, and those are the ones who don't like my way of probing, and they feel, why so many unnecessary questions, and that sort of reaction I get from the. So it's not about class, the lower class. Of course, substance addiction is more in the slum area. I But that class of people have never come to me. But the smaller the family and the more close knit they are with the grandparents and many of the relatives, those children do better mentally than the children who are holed up with babysitters and with a nuclear family. That's what I've seen.
Okay. Thank you so much for that. Um, we have a lot of programs like app based, like I think somebody's already put diabetes reversal, those kind of things, or peer groups, school programs. How do you think these can affect, help teenagers with obesity or teenagers with diabetes? How do you feel this would kind of bridge the gap in treatment modalities? Have you got any experience with that, like app based um,
No, I have not
approaches?
done that, Dr. Vinita. I've
Mm,
dealt with them individually, because the children also, even only at the third or fourth visit, they open up, and
correct,
they want me to keep it a secret. Like, they take the appointment last or very early, so that they are not seen by anybody. They are so secretive. It's stigmatized, actually.
correct.
Actually, obesity and a child getting diabetes, type 2 diabetes, is stigmatized by the society. So
Hmm,
the parents also, they say, ma'am, give us the early first one or the last one where we are not seen. So this
right.
app-based, I don't know how it will help them. I have no
Okay.
experience with that.
Yeah, I think it works more in adults. For children, probably it
Yes.
will not help out. Thank you. This is so helpful. I want to now open it up for people to unmute and maybe ask questions, or if there's anything more you'd like to share, Dr. Indu, that also we can do. Just
Yes. So, I feel, the child develops very high diabetes, and then only they present to me. I've never seen people in the early stages present to me. They always come with high HbA1cs, or some other doctor has put them on high doses of insulin. That's how they present to me. For a preventive thing, nobody has approached me, unless a little obese child has accompanied his parents. Then I tell them, which standard are you studying? What happened? There is a family history. So, like that, we gently put it forward. But I think the family physicians, and there should be preventive camps in schools where you can pick up children with early
early.
diabetes. So, there
Yes,
should be preventive camps where we can deal with it early, not them to develop full blown diabetes and then coming for treatment.
right. Very true. Right. Um, if there are people who need, there is a question. Actually, Joyce has put a question. Is type 1 second. Type 2 diabetes is reversible. Is it reversible?
Type 2 diabetes is definitely reversible, but the whoever is treated, the adult or the child, whoever type 2, uh, they have to be motivated. They have to be in the game. It is not a doctor's job.
Hmm.
So highly motivated ones really reverse their diabetes. And children can definitely reverse, because the first 5 years is the window of reversal, where the pancreas is fully healthy. It will again, bounce back and take care of the carbohydrates which we put into our stomach. But after 10 years, 15 years of long standing diabetes, very difficult to reverse it. We can just control it. At least one or two maintenance drugs will be there in the list. So my honest answer will be, if the child or the adult has been having just been diagnosed and they've been having diabetes for the first 5 years, very good chances of reversing and remitting them, and keeping them remitted with good cooperation from the patients, because it is 20% only the physician's role. 80% should come from them. They should be only highly motivated people can keep it off.
True. Thank you. Thank you so much. Mr. Lloyd, you had asked a question. Can you just clarify that? I wasn't. Can
Yeah,
have.
yeah,
Yes.
yeah. I think Dr. Indhumathi was saying some leading questions where you want to probe. I was wondering what would be those leading questions where you want to probe for someone. Could you throw some light on some examples of those questions?
I
Yes.
think, yes, Dr. Indhumathi, you have anything? In what context was it? Leading questions?
Yeah, I think when people come to the clinic, Dr.
Right.
Indhumathi was referring to saying that we got to ask them some leading questions. So I just picked that up, but then that went a different side.
Right.
So I just said,
Right.
So leading questions is, as I told you, sir, do you have any cuts? The young children, boys who come in, do you have any cuts on your penis? Because they don't open up. So we ask it. So, and then, do you have any problems with your periods, your monthly cycles for girls? Do you see any ants on your toilet seat
okay,
after you flush? So these are the leading questions which
okay,
they will not volunteer. We have to look for it.
okay. Thank you.
Can having neem leaf boiled with water bring down diabetes every day if it's had?
No, it is a placebo effect. It is just a placebo. You can have your Karela, you can have your neem, and you can have your methi. It's just placebo. If you have diabetes, it is diabetes. It is insulin resistance. Only
Okay.
diet and exercise works. Neem leaves will not work, will not bring down the sugar. It may give you a feeling that you've done something, but it is not going to help your diabetes in any way, scientifically.
Thank you. Dr. Pooja, you had something you would like to unmute and ask? Dr. Pooja is also part of our
Yeah.
team. She's a dietitian with us. Yeah, please.
Okay. Good evening, ma'am.
Yeah.
I have these two queries. That what exactly fasting serum insulin in teenagers you are expecting?
See, it should be a normal level below 24. But most of
Hmm.
these kids with PCODs and overweight, even
Hmm.
with HbA1c of 5.9, they will have hyperinsulinemia. So when a child
Hmm.
comes with those black spots on their
Hmm.
legs
Hmm.
or in their elbows,
Acanthosis, ma'am.
yeah, acanthosis, yes, that's what I
Hmm.
mean. But
Hmm.
so they will go to a dermatologist, and they go
Hmm.
around and around for
Hmm.
treatment. But it is
Hmm.
actually insulin resistance caused by high insulin levels. So such
Correct.
people, you'll have to go forward and do another two tests, Dr. Pooja. Please do
Huh?
the C-peptide levels and
Hmm.
HOMA-IR. It is done in all the labs. It's called a HOMA-IR. It's a calculation actually. Fasting insulin
Okay.
levels into fasting blood sugar by weight. That's the formula, and you can get the HOMA-IR. And below
Okay.
1 is normal, and when it is above 2, it is insulin resistant. So when we show the
Okay.
numbers to them, even though they are just having 5.9, and 5.9, it's just pre-diabetic, they just brush it off. But when you show these numbers, see, your insulin levels are so high, your C-peptide levels, especially the postprandial, if it's more than 5, it is a red flag where we have to treat. And the third one,
Okay.
as I told you, HOMA-IR.
Hmm.
This should be done, I think, when any teenager who's even 1 or 2 kgs overweight and who has acanthosis nigricans. We don't wait for the HbA1c to go, up and then present as a full blown diabetes. They
Okay.
they have to be caught early.
Okay. So,
Because
ma'am, you are
most of the
saying
children coming from other doctors, they just have a fasting insulin level, especially PCOD
correct,
girls. That's not enough.
correct,
You have to do the
correct.
C-peptide fasting, C-peptide postprandial to see how much
Huh?
of insulin resistance they have. And
Okay.
third is that HOMA IR, very, very important.
Okay. So, ma'am, you are saying more diagnostic uh, protocol would be C-peptide level and HOMA-IR, correct?
HOMA
More
IR,
than
yes.
fasting. Okay, all right, got it, ma'am. And second question that I had was, how to most of the times when I treat this diabetic patients with the
Hmm.
help of diet that I prescribe, so sometimes I see that they slip into hypoglycemia because the diet that I give and the insulin which is already going on or the OHDs which are already going on. So how to tackle that very the fine line where I
Yes,
have to educate them that you can slip into hypoglycemia and then you might have to not take the dose. So I tell them to measure their, and especially I've seen this in pregnant women, I've seen this in adults because they're the response I can see faster with the diet. So how to educate them or how to manage
yeah.
that time of hypoglycemia
So for
practically.
this, very important is you'll have to be in sync with the treating diabetologist,
Correct.
whoever is treating. So, and the
Okay.
two culprit drugs are only sulfonylurea and insulin, nothing else. The others will not bring it down, like
Okay.
gliptin or SGLT2 or a pike. Sorry, you'll just bring it down
Okay.
to 120. It's not going to slip below that. So these two
Okay.
culprit drugs, if you see in the prescription,
Hmm.
glycoside or a glimepiride or insulin,
Huh.
you'll have to get
Huh.
in touch with their doctor, and
Hmm.
it should be a shared decision making. You have to stop them
Okay.
once they go on a robust diet. Usually in my clinic, I handle both. So the patients, they usually send the readings twice a week, Wednesday and Sunday, and in 2 weeks of proper diet, these two are weaned off. Insulin is stopped
Okay.
and the SU is stopped, Dr. Pooja.
Correct. Okay. Okay, ma'am. And how to understand that these teenagers that the today's topic
Hmm.
is that they are slipping slowly into the total metabolic syndrome and how to reverse them back from the whole syndrome, or is it that they are going to require a treatment all their life?
See, we cannot wait for them to develop full-blown metabolic syndrome. Even when they have
Hmm.
one aspect of the metabolic syndrome, like
Hmm.
acanthosis nigricans or a
Hmm.
raised
Hmm.
waist hip ratio or missing their
Hmm.
periods or
Hmm.
having a little bit of LDL level, it's very surprising for me. People are coming to me with,
Hmm.
children are coming to me with high
Hmm.
LDL levels
Hmm.
or high
Hmm.
triglyceride levels. So
Hmm.
even one aspect from the wheel, if you pick up, we have to be proactive. We can't wait
Okay.
for the full metabolic syndrome to develop in the child.
Okay.
So one
Okay.
aspect also is there. We catch them early and we put them. And as you asked, most of the kids, if they are counseled well and if their family support is there, completely we can reverse the metabolic syndrome and they do well. Only
So
in
off
families
of
where.
okay.
Mm.
Fine. So ma'am, you mean to say off of medicine over a period of time,
Yes,
all the allopathic
mostly we,
medication?
we have to use only metformin and gluco acarbose. These are the
Hmm.
two which are
Hmm.
approved for children. We cannot
Hmm.
use all what you're using for adults.
Okay.
And in a insulin resistant child, for example, if the HOMA IR is very high or C
Hmm.
peptide is very high or the
Hmm.
insulin levels are very high,
Hmm.
again giving the child basal insulin will create counter, it will be counterproductive. So,
Hmm.
though the guidelines, if you have read the guidelines, they'll say if a child
Hmm.
comes to you, start off
Hmm.
with diet, exercise, and a basal insulin. I don't use
Hmm.
that. Metformin
Hmm.
and acarbose is more than enough. And when the child
Hmm.
learns, okay, if I eat less, I'm healthy and I'm losing weight, I'm losing
Hmm.
inches, then
Hmm.
we can wean them off from metformin and acarbose. Mostly it takes around average, I can say 3 months.
Ma'am, nowadays
Right.
I'm seeing this obesity factor from 8 years of age till, I mean, there is no upper limit to it. And sometimes it becomes very difficult for them to lose weight because of their upcoming exams and there is a competitive nature. So what you suggest in that case, when the diet and exercise is practically not possible, put them on a therapeutic doses for
Yes,
a
yes.
while?
Yes, they
Okay.
have to be. In fact, one of the kids who came to me frankly told me, "Ma'am, I'm not able to follow your diet, and I go in the sly and buy those momos and I eat it without my parents' thing." He told specifically, please send my parents outside. And he told me. So I asked, what is your problem? He said, every 1 hour I feel hungry and I have to fill my stomach. So it is actually reactive hypoglycemia. So the
Mm.
insulin
Okay.
levels are so high. So unless you break that vicious cycle, the child will never lose weight. So this
Hmm.
child is 15-year-old and I put him on Ribelsis semaglutide. He's doing very well. Now he's reduced
Okay.
that binging thing and his sugars are settling down. So it is individualized, Dr. Pooja, but most of these kids who have this reactive hypoglycemia, binge eating, we have to break that cycle with pharmacotherapy. Only advising them and giving them a
Yes,
diet will
yes,
never
ma'am.
work.
Yes, ma'am. True, true. Thank you, ma'am. Thank you for your
It
time.
is
Thank you.
individualized. You have to select the proper child who needs the pharmacotherapy, and the children who can just when they have a supportive environment, as I told you, grandparents who really nurture the grandchildren, very easy with lifestyle modification alone.
Correct, correct. Ma'am, thank you very much. I got this a very good takeaway to do the more specialized test. So
Yes.
we'll not miss
Yeah.
any link.
Plus,
Thank
you
you,
have
ma'am.
to be in touch with your diabetologist when you're down titrating the doses. You can't just give a diet and leave them off with the SU and insulin. That's going to bring down the sugars very fast and
Yes,
land them
yes,
in
ma'am.
the with a
That has
hypo.
happened many a times. That has happened with my patients. So I already guided them in the beginning that this can happen and this is how we should go about. Thank you, ma'am. Thank you.
Thank you.
Thank you very much. Yeah.
Thank you. I
Thank
think
you, Dr.
there
Matthew.
was, thank you. I think there was one more question, some more query. If you can unmute. I don't know your name. I can't. iPad.
Sir also raised his hand, I think.
Yes, yes. Dr. Matthew also raised his hand.
No,
Yeah.
I just wanted to mention that nowadays with this continuous glucose monitoring systems, like we have that freestyle which we put on the arm, every 10 to 15 minutes automatically it records the blood sugar
Yes.
24/7 and it sends you a notification on your phone. So that actually helps to a great deal for whenever there's any new medication being added or any change in the lifestyle, then these continuous glucose monitoring systems like the Freestyle Libre and another one is there which I'm testing. They are very useful. 15 days you can wear them. They are waterproof and you can do all your daily activities with it. And it really helps to give a good graph, especially what you're eating and how much it is actually affecting your blood sugar. Because in each person there's a big variability. So the same food that you eat may not increase your sugar, but somebody else it may really increase the blood sugar depending on their insulin and the metabolic resistance. So the freestyle has added a whole layer of
Yes.
personalized treatment and data. The more data we get on the blood sugar levels, the better the clinicians can actually work and better control the blood sugars in participation. Because nowadays talk a lot about participatory involvement of the
Yes.
Yes.
patient and the healthcare personnel. We are discussing with one another and collaborating on the treatment because we celebrate
True.
that collaboration actually. And that is how the best whole person care treatment can be
Yes.
given. And it is a teamwork, not only the patient, even the family members, the community, everybody is involved in it.
Yes.
And that's how we actually make an impact on the sugar. Yeah, there's a question on ketogenic diet, I think, which was put by Joyce. Maybe one of you can answer that as well.
Dr. Matthew,
Ketogenic.
what is the name of the company? Or any name
Freestyle.
of the company that you can
Yeah,
suggest?
the commonest one or the one which is most widely available is the Freestyle Libre. Freestyle Libre.
Okay.
And
PG.
you get a small patch which
Third.
you wear on your arm and you get a sensor, or you can do it on your mobile phone. Now, from last year, November, in India, the app has been launched, which requires your phone to have an NFC enabled phone. Then you can download the app and you can monitor it. So it will just keep giving you the updates. There's another company which I'm testing now, but in another 15 days, I'll give the result of that. That also looks to be promising.
CGM. Yeah.
So, so there
So it's
are
a continuous glucose monitoring
yeah,
device.
continuous
That's
glucose monitoring. So you don't need to prick your finger tip to get the blood. This is actually a device which is put on your arm and it goes into the subcutaneous space of your body and it measures the blood sugar from there.
Okay. And how much does this cost approximately, more or less?
Around 5,000 rupees for 14 or 15 days.
Okay. Thank you.
yeah. Dr. Nishta had a query, I think, and then we can take Joyce's query. Dr. Nishta, do you want to unmute and speak?
Hi, everybody. Good evening. I'm Dr. Nishta Dalwani, and it was a very good seminar. Just a few personal only from my family point of view. I'm asking nothing. What is the genetic basis, ma'am, for, if the father has diabetes, what are the chances of the teenager or the child, and when should we do the blood test? Because there's a family history. So when should we, actually start doing the blood test to know if the teenage also has developed, and what are the chances of the child developing diabetes? So the genetic basis is what I want to know.
Yes. Genetic aspects were more important a couple of decades back, doctor. Nowadays,
Hmm.
almost half the population is reeling under diabetes because of the change in the increased screen time, too much of junk, and eating at odd times. So
Hmm.
even when the father or mother are diabetics, if you probe their history further, their grandparents would have been pretty very healthy. So now we have to treat every child who's overweight as has a risk factor of developing diabetes. Family history is actually very negligible in these cases, madam.
No, no, but what I want to know is when we suppose if there is a family history, at what age should we get the test done? Because very often I find when for the
Puberty,
insurance we do a basic, test, and that time suddenly we come to know that like my own husband's
actually,
diabetes
yeah,
was just detected by just
that's
one,
all.
we had to do it for insurance, and we came to know that he's a diabetic. So at what age should we do it ideally for, like,
Yeah.
now for my
So,
son, if I have to get
uh,
what is a genetic predisposition?
when
I
they,
mean,
yeah,
it's
I understood your question. So when there is a genetic predisposition, during the puberty, that is the time where it raises its ugly head. The
hmm,
pre-diabetes or diabetes or metabolic syndrome. Till that time, the pre-pubertal age is relatively protected. But the sudden hormonal changes in the boys as well as
13 to
girls,
14.
yes, yes.
Hmm,
Puberty, that time only mostly the type 2 explodes in the children.
right. And second question, ma'am, is any of the diabetic drugs are known to cause acidity? Is also one question, because I've seen a lot of the patients. In fact, I had one case of a patient complaining of abdominal pain, and he had been to to most of the gastroenterologists. He was a diabetic, and I referred him back to the physician saying that, maybe one of the diabetic, because it's for long-standing abdominal pain, scope is done, no, everything was normal, and so first they labeled him with psychosomatic, referred to psychiatrist, and he was sent to me. But I found that, is it known that any of the diabetic
Yes,
anti-diabetic drugs are known? Because we changed the medication and the acidity settled. I referred him
yes,
back to the physician, and he changed the anti-diabetic drug, which was going on for years, and the pain went off. So, I mean, is that
yes,
and which are
ma'am.
the
That
known
is very
drugs which are
common.
known? Which
Yeah,
are the
and
known drugs?
Known drugs is mostly metformin, but metformin is gold standard because it is a sensitizer. So only
Okay.
in people who really develop pain, diarrhea, or vomiting or gases, which is actually 5% of the population, we stop the pill and put them on other oral drugs. Otherwise, if we counsel them properly and start with a low dose and gradually escalate the dose, most of them can tolerate metformin. Metformin is the culprit, which and also the Oglibos and Acarbos. These three are the drugs
Yeah,
which
he was,
we
and we
treat.
changed the medication, and actually the problem settled,
Yes, yes,
So we
it
were
settles.
labeling him as psychosomatic, and, and referred, but when the physician changed the medication, the problem did settle down. Yeah, that's it. Thank you so much.
Yeah, thank you.
Yeah, we have two more quick questions. So, Doctor, can you just help us? One is Joyce had asked about keto diet, I think.
Keto diet is quite popular, but the what to say evidence we have to talk only evidence based medicine. We cannot just talk what is on Insta and the reels. So evidence based medicine, ketogenic diet or the paleo diet, which is very close to our what the forefathers did, is not sustainable in the long run. That's what I have seen. Of course, going on a keto diet or a paleo diet with very less carbs or no carbs at all, it brings down the sugars and they remit. But the most of them, at least 99% of the people who have embarked on a keto program are not able to sustain it. And ultimately, when they again go on the normal diet, it relapses back. And
True.
there is no evidence-based medicine to say that keto diet will cause so much of remission. And that we don't have any such data. So it is all
True.
Insta, and it is popular, but they are not able to, you will not be able to
Sustain.
sustain it.
Yes. I think that's what we need to look at for any diet. If it is not become your lifestyle, then it's going to
No,
flop.
it
It's
is
going to
not going
fail.
to flop.
Yeah.
Yes.
Yeah. So if you're able to fully change your whole lifestyle towards keto only, then you will sustain. Otherwise, you will not sustain.
No.
And I think Rekha has also asked a question. Rekha, about can you share healthy lifestyle for teens? Does the cravings on sweets, chips, junk food affect teens' behavior and physically as well? Teens who eat continuously.
Yes, definitely. It affects them, and they also are intelligent enough to realize that something is abnormal in them. Most of the children who binge eat, they usually open up when the parents are not around. Some of the children are very proactive. They say, "Ma'am, I want to talk to you alone. Please send my parents out," and that's how they open up. And they are very intelligent enough. Internally, they get a internal feeling, the gut feeling, I can say, that something is wrong with me. Why am I feeling hungry every hour, and why am I constantly hooked on to food? So most of them are aware of it, and once we say that yes, better, it is a physiological thing which is happening. You are not diseased, or you're not abnormal in any way. That's how we go with the flow, and we show them the numbers. Look at the C peptide; it's so high. Look
તો
at your
પાછી આવે ને
fasting.
કદાચ ખોલું નહીં ને તો સામે ચાવી છે તો ક્યાં છે નીચે
I'm sorry about that. Yeah.
Yeah, no problem. So that's how we handle them gently. But as I told you, Dr. Vinita, even I'm a novice at all that. I'm suddenly exposed to young boys and girls coming to me with diabetes. I'm a novice at that. That's why I was overwhelmed, and I sought the help of you and sir. I thought, going to schools and doing something will curb this. So even I am at a loss of how to deal with this sudden pandemic or epidemic of childhood obesity and diabetes. It's all very new for me.
Great. Yes. Thank you so much. Thank you.
Can I do one question
Yes,
if
yes.
it's okay?
Yes,
Or you
please,
can write about it later,
No,
but
no,
just a
you
question
can.
to put it out there.
Yes, please,
Yeah,
put
so
it
I
up.
mean, I'm not a medical professional in any way. I'm a teacher and a parent. So from a parent and a teacher perspective, how can we help these children when we notice this, what is happening, the red flags that you talked about? Once we notice that, how can we be of help in any way? Like for their mental well-being, because again, they are with us most of the time than they are with the medical professionals, no? So how can we
Yes.
help in practical ways?
So they have to be picked up early. First thing is empathy. I think empathy will allow the child to open up to whoever is probing the matter, whether it be the doctor or the teacher or the parent. Empathy is very important. You can't poke your finger on them and say you're obese, you're overweight, you brought it upon yourself. That's not going to work. So subtle signs, as I told you, the child academically going down, or not having eye contact, not being happy, or mingling with the peers. These are all red flags which whoever the caretaker has to probe. And secondly, since I heard that you were a teacher, there should be remedial measures for even this type of things. I think remedial education is there, only academic children who are poor academically. There's nothing to pull them out of subtle depression and anxiety, or bring that child out of that shell which they are locked in. So I think that should be taken on a bigger level. One person cannot do everything. I think it's a teamwork, and the schools have to work on it. As Dr. Mathew said, policies have to change and dealt with this matter. One person like you and me cannot do anything, madam. It has to be, the red flags are very, very subtle, and we should be intelligent enough to pick it up and give some importance to it.
Very true. Thank you. Thank you so much. Thank you all for just participating and asking those questions. I think it made a lot of difference. Is there something more? Somebody is just can take one last question. Yes, Minnie. Yes.
Yeah. I am Vinny Maris. I'm a teacher. in my class there is one boy who's little means I feel like obesity. I'm feeling, but I never, because children also bullying him like hathi ka bachcha hai. So I used to make him standing for him. That's all. But whenever I spoke to his speak to his parents, they are always busy, big family, and the mother used to blame him only, the child only. And education wise also he is very low, and his movements are also are very low. Very slowly he walks, and his body face and everything is very like fat, but I cannot say like that. No. So should I mention to the parents? I don't know how to, because if I tell anything, if the parents will get like something. So I was feeling like, how should I tell them, or to uh, sorry.
So you should tell them, ma'am, and something has to be done for the child, because sometimes it is just undiagnosed hypothyroidism. I had a girl who had delayed puberty and overweight and loss of hair, and she was brought to me, and it was actually hypothyroidism. The TSH was so high, and a single pill of thyroid tablet reversed everything. So there can be medical reasons for the child's overweight and the dull, whatever you're saying. So the parents have to be told about it, and some action has to be taken. We cannot have these inhibitions. How will they take it? I think those days are gone. We have to step in for the kid and do something for the kid.
Very true. True. Yeah, I think we must, whenever we suspect something, look at it from the holistic picture. Look at it from the body, the mind, the social, what is the social environment? Because that environment also may be causing some things in the child. So there could be many factors. So it could not be just one thing like diabetes, or just one thing that the child is eating too much, or one thing that the people are making fun of. It could be multiple factors which would be affecting the child, and everything needs to be addressed by a team. So I think it's very
But since she
important.
has picked it up as a teacher, I think
Yes,
it's time she opens up with the parents
parent.
and
Yes,
make them empathetic. Yeah, something has to
yes,
be done. We cannot just ignore the child.
correct, correct. It could lead to other problems later
Yes,
for the
yes,
child. So definitely,
yes.
it's good that you have picked it up, and it's good to take the child's parents into confidence. Maybe show them some videos, or give them some form of awareness. Maybe even organizing awareness sessions in the school as a whole, because it's something that the entire school would need, probably even the other children would need to be sensitive and empathetic towards their classmates. Yeah. So thank you. I think we've overshot a bit on time, but I feel this was such a amazing session. I think it was really good. Thank you, Dr. Indhumathi, for your time. And next month we are planning to have a session on PCOS, because that's also another very important topic. Many girls facing this problem, young girls, and Dr. Indhumathi will be talking to us. We may have somebody else also on the panel, but we'll send out messages to all of you.
We
And in
can
the
have also a
meantime,
gynec, Dr. Vinita, because
yes, yes,
most of the
yes.
girls present to the gynecologist rather than to the endo.
So yes, yes, we'll have some more on the panel. So I want to thank each
And
one of
also,
you all
I
for being.
request you and sir to, open up some opportunities for me to talk in schools,
Yes,
so that,
we're looking
it
at that.
goes on a bigger level. Yes.
Yeah, we would like all those people who are here on this team also just to look out for contacts in different schools in your localities, to just open up, and we'd be happy to talk to different people. Yeah. Yes, polycystic ovarian syndrome. Sorry for the terminologies. Yeah, so this is a problem with young children, young girls not getting their periods on time. So these are some things that would help parents and teachers or young adults to get it. Yeah. Yes, sure. We'll get you the contacts of Dr. Indhumathi for opportunities to speak. Yes. So thank you all. I'd request all of you all to just quickly take a minute to share your feedback on the feedback form, which I've put up on the chat box. I'll also send it to you personally. Thank you.